Yeah, you're right. So that might be a lot.
Yeah, I did too. You're
Saturday and then next week. Whatever's See how that works. So she's got to get on from there. She's not like right? 6 years.
I realized they were lunchtime. I think you should have.
Doing this? Well, yeah. Perfect. Well, we looks like we have a big crowd on online on Teams, and I will, we'll do the same thing we've been doing with our the QR code and link for CME credit. That'll be in the chat for anybody who needs it. Wanted to really, recognize and thank our speaker today. We don't need an introduction as if he's a true visitor, but unfortunately he's soon going to be a visitor. Dr. Springer has been a rock and part of our teaching faculty, and obviously a incredible leader nationally in the hip and knee world. And we are very jealous that he's sort of going back to his roots. I think many of you know he trained at Mayo Clinic, and he was recruited, and they had the unfortunate for us access to
Can't mute people either, sorry.
thanks to the Mayo Clinic in Jacksonville was ready for new leadership, and they who?
Who's it?
Oh, yeah, we're good.
Okay. Sorry about that. So he's been recruited and hired to become the next chair at Mayo Clinic in Jacksonville. I know he has several, close friends there, and I think it's an incredible, development and leadership opportunity for him. So obviously we all send him with the best wishes and encouragement, but are very sad to see him leave. I have the, additional connection that his two of his boys are in school with two of my kids. So I know that there's a lot of people across the board. I'm sorry to see the Springer family moving to Florida, but it's going to be an incredible opportunity, and I'm really happy that we were able to work out a day to have him sort of give last farewell lectures to us today. So without further ado, Bryan, we really all thank you for everything you've done here, and know that you'll continue to be a mentor and friend to everyone here. So.
Thanks, Josh. Good morning, everyone. Certainly is bittersweet to be standing up here, that's for sure. I was thinking on the way up here, this is kind of the last time I'm probably going to use this slide background. Actually, also
He'll be happy if you give it this.
and actually thinking about how painful it is going to be to change all my talks over to a new slide background. But thank you, Josh, for inviting me, and Bryan and Susan for the invitation. I'm going to try and cram in two talks this morning if I can. One that's a little bit scientifically based, and then maybe one that's a little bit more kind of mentorship based. So hopefully I'll have time to go through both of those without really rushing. But I want to talk a little bit about a topic that we've done a lot of work that actually started with the idea out of here. And I'll try and tie that back together with my second talk just a little bit when we talk about, leadership and things along those lines. But we're going to talk first about just antibiotic prophylaxis for dental procedures. And I don't have any disclosures that are specifically relevant to this. If you're not really interested in this topic, I started with my conclusion slide, so you can kind of tune out after this. But it really is applicable more to just hip and knee replacement. I think it kind of has broad applicability, but would argue that this topic is probably one of the most controversial and unresolved issues in total joint replacement. And part of the reason is there's been this wide divergence of opinions over the years between Academy and the American Dental Association. They've come together, they've grown apart, they've come together. And really, despite a lack of data, which I'll show you, that shows a causal link between a patient having an invasive dental procedure and developing a periprosthetic joint infection, roughly about 90% of orthopedic surgeons still prescribe antibiotic prophylaxis for dental procedures. And while we think that may not be a lot to that US healthcare system, it has a cost of about $60 million. And that doesn't take into account issues with allergic reactions, adverse reactions to the antibiotic, the development of antimicrobial resistance, which I'll touch base on. So I always say my job with this is not really to try and convince you, but as you go out into practice, just start to have the conversation. And I've been fortunate enough to give this talk at several grand rounds around the country. And that's really what I try and emphasize here. Just start having the conversation among your group and see if there is evidence to change the practice that you're doing. And sometimes the conversation goes like this. Literally, I was in Georgetown last week giving grand rounds on this topic. And I was on the plane and I got this text from one of our former fellows, Nick Calaccio, and he said, "Hey, random, have you stopped recommending routine antibiotics for dental visits for the first couple of years post-op?" And he attached this link in here. And this is actually the article that we wrote. It's in a journal called Dental Economics, right? And my response was, "Yes, I have. I'm glad to see that you subscribe to Dental Economics." And he said, "Well, we all have our vices, but actually we had a local dentist send me the article, and we've been discussing as a group the potential for stopping routine antibiotic prophylaxis." So again, this is just about kind of starting those conversations and thinking a little bit differently about the data. So if you go back and look at periprosthetic joint infection for total hip and knees and early periprosthetic joint infection, so that's what's related within about 3 months of having a surgery, because that's generally what's thought to be related most likely to a procedural contamination. Back in the 1970s, when we first started doing hip and knees, it was 12%. If you look at the most recent data, it's somewhere around 1% to 2%. And much of that has been because of the work that's been done, getting patients ready for surgery, preoperative optimization, selecting appropriate antibiotics, decreasing risk of wound contamination, things along those lines. So it made a lot of headway in that arena. But late periprosthetic joint infection, or what we call late acute hematogenous infection, so you're 2 years out, you're 5 years out, and for some reason you develop a bacteremia that then spreads to your joint, you develop an infection, has continued to garner significant attention. And some would argue, does this really truly even exist? But that's kind of for another talk. But this could argue is something that remains a risk throughout the patient's life. And it's really, if you go back to about 1955, when the cardiologist and the American Heart Association developed guidelines for the prevention of infective endocarditis, right? So people that have heart valves, things along those lines, undergoing dental procedures in the 1970s. In the 50s, they recommended that all those patients should receive antibiotic prophylaxis, all those patients. And so this kind of caught the attention of orthopedics and our academy and led them to think, is this something really that should be in parallel, or is this paradigm kind of applicable to patients having total joint replacement? And here's the 1950s. I won't belabor all of these guidelines. They've had several throughout the past decades, but in the 1950s, they recommended antibiotic prophylaxis for every patient that could be at risk for infective endocarditis, that they receive antibiotic prophylaxis for the rest of their life. And it was really their efforts that led to orthopedic surgeons to call to do this for patients that have total joint replacement. And so, again, it begs the question is that paradigm of infective endocarditis or prevention of infective endocarditis applicable to patients that are having total hip and knee replacement? And these are the guidelines that have been developed through the years. Many of you have probably been around through some of them. Many of you may be familiar with some of the more recent ones, but they are very confusing. They're very challenging. And it's not that it's the Academy's fault or it's the ADA's fault. It's predominantly because, as you know, with these guidelines, there's just not a lot of literature for them to be able to put any teeth behind the guidelines. But I just kind of took a smattering of them. So this was really one of the first one in 1997, an advisory statement. They said no antibiotic prophylaxis for patients with pins, plates, or screws, not routinely indicated for most dental patients, but advisable to consider pre-medication in a small number of patients, right? So they kind of called out the immunocompromised patients or those at increased risk, right? And then in 2009, they kind of changed tracks, right? Albeit really with not any additional data, and I'll touch bases at that, but they said, given the potential adverse outcomes and the cost of treating an infected total joint replacement, the Academy recommends that clinicians consider antibiotic prophylaxis for all total joint replacement patients for any invasive procedure, and that all patients should take prophylaxis for the rest of their life. Right? This is a pretty profound change from their statement that had been posted previously, and this caught the attention of a lot of orthopedic surgeons. And then to confuse things, kind of the American Dental Association went rogue in 2015 on their own and said, in general, for patients with prosthetic joint implants, prophylactic antibiotics are not recommended for dental procedures prior to the prevention of, to prevent patients at risk for periprosthetic joint infection. So completely diametrically opposed for what the Academy recommended, right? So where does that place patients? It puts them in the middle, right? They come to see us, we tell them they need antibiotic prophylaxis, they go see the dentist say, no, you don't need it, right? Or the dentists are concerned that the orthopedic surgeon told them they did need it, so they send them home, reschedule your appointment, come back when you take your antibiotic, come back when you have your antibiotic. So it created a lot of angst and ire among orthopedic surgeons and the American Dental Association. So the argument is, though, if you look at the prior literature that's been used for all of these guidelines, whether it's the ADA, the Academy separately or in combination, is that they're woefully underpowered and they suffer from really statistical fragility, right? So you change a couple patients from one group to the other group and your p-values change and they're no longer significant because the numbers are so small. So if you do a power analysis on the association of invasive dental procedures and development of periprosthetic joint infection, you try and do that, say you're going to formulate a prospective randomized study. If you want to show a 10% difference, you need 7,000 patients. If you want to show a 5% difference, you need about 8,600 patients. So really big in each group. So really big numbers if you're going to do a prospective randomized study. Probably not feasible economically to be able to do something like that. If you go back and look at the 5 studies that have been published to date on this that were used to make all of those guidelines, and you combine them together, right? Again, there's the power analysis numbers, right? All of these were 532 patients combined. 532 patients combined is what we were using to make those guidelines, right? So highly underpowered to make any kind of decisions about what we should be doing. So let's take a look at some of the more recent data, because this has really changed in the past 2 or 3 years, and this is really kind of what got me involved in this. I assume they probably asked like 10 other orthopedic surgeons who's like, I'm not touching that subject. I'm not being the one that, is against antibiotic prophylaxis. And I was kind of dumb enough to say yes. But it's really pretty amazing as I've gotten involved in this and kind of, dove into this, a little bit more, and especially been involved with a lot of dentists and oral surgeons who I would have never had any other exposure to. So this was a study that was published in JAMA, the largest study to date. And it's really interesting, the methodology that was involved in this. So basically, we looked to see if there was an association between invasive dental procedures and the development of periprosthetic joint infection. As I mentioned, really hard to do it prospective randomized study. So use this case crossover methodology. And basically what a case crossover methodology is, it studies the effect of a transient event, so in this case, an invasive dental procedure, on triggering the subsequent outcome, which is the development of a periprosthetic joint infection. Patient goes to the dentist, they have an invasive dental procedure, and they develop a periprosthetic joint infection. And can we follow those? But what it does is it eliminates this selection bias and confounding, because each individual patient serves as their own control as we look at them backwards over time. And so this is a study that we're fortunate enough to get some funding through the NIH. And the challenge is you can't do this in the United States, right? It's a really hard study to do in the United States just because of databases and confounding issues with whether or not we give patients antibiotics or not, and just being able to track patients. But in the national healthcare system in England and Wales, it's actually pretty easy to do, right? Because all hospital admissions, because they're under one healthcare system, the NHS, are reported to a database, right? So all total joints, all total knees, their national registry captures like 99% of total joints. Interestingly enough, all of their dental procedures are also reported to the NHS, single healthcare system. So you can create this unique identifier, this unique linkage between patients that have invasive dental procedures and have total joints, and look at the number of procedures that they've had over time, right? So invasive dental procedures are considered having your tooth pulled, a scaling, which we call a cleaning, and any endodontic procedures. And then non-invasive dental procedures are like simple exams where they're just looking in your mouth and things like that. So that could kind of serve as a control group. But the interesting thing is in England and Wales, they do not, and they have never recommended antibiotic prophylaxis for dental procedures, right? They don't give it, they never have. And so it's never been a standard of care to be able to use it. So again, you're able to create this kind of unique linkage or data set. So able to look at 23,000 patients that were admitted to the hospital with a periprosthetic joint infection, and then link their dental records moving backwards over about an 18-month period of time, about a 15-month period of time. And so you can see when we linked them, we had about 9,427 patients that were admitted to the hospital and we could track their dental procedures. So this is a little bit confusing, but this is kind of what that graph looks like. So if you look at the purple kind of vertical line there, that's the admission to the hospital for a periprosthetic joint infection, a late periprosthetic joint infection. We excluded any patients that had infection within a year or any patients that had prior history of infection. So that purple line, that vertical purple line there is admission to the hospital. The blue shaded area is the 3 months prior to that patient being admitted to the hospital for a late periprosthetic joint infection. And then that 15 months prior to that is the case control period, right? So we could track every dental procedure that each individual patient had. And then if they were admitted to the hospital for a periprosthetic joint infection. And that the red line, the solid red line, is all procedures combined together, right? And actually what you see is the invasive dental procedures actually went down in the period of time when those patients, just prior to those patients being admitted to the hospital. So there are actually fewer invasive dental procedures in the 3 months before an admission to the hospital, right? And if there was a link between an invasive dental procedure and a periprosthetic joint infection, you expect the incidence of an invasive dental procedure actually to be greater when in fact it was less. And then we didn't see any difference when we stratified it by any type of procedure. So non-invasive procedures, extractions, having your teeth cleaned, or any type of endodontic procedure. It just didn't play out that there's a higher incidence of that. So there are some limitations anytime you use large database studies. Remember, you're looking at associations, not causations with database studies. That's an important thing to remember. It's hard to identify organisms. So if we're looking at strep viridans, which is the oral organism that we most commonly think about pathologic from the mouth, it can be hard to track that. But nevertheless, this study was 30 times larger than any study that had previously been done. And it had a 90% power to detect an actual 9% higher incidence of invasive dental procedures in the case and the control period, and actually showed 11% lower incidence. And the benefits of this methodology is there was no confounding use of antibiotics simply because it wasn't recommended. There was no recall bias because each individual patient served as their own control. Now, subsequent to that, this has been reproduced really 2 additional times. This is the Taiwanese national database. Same thing, don't routinely recommend oral antibiotics. large population of joint patients and dental procedures that all kind of flow into one single database. And they had 250,000 patients in their database, and they were able to match over 57,000 patients. And they had a smaller subset of patients that they were able to track based on prescription records, whether or not they had antibiotics or not. And what you see is really the same exact conclusion. No association of a periprosthetic joint infection and an invasive dental procedure, no difference in the procedure type. And then for that subset of patients that they did see received antibiotics, doesn't make any difference if you receive antibiotics or not. And then this was a paper that was just published about 2 or 3 weeks ago in Core. This was, again, a South Korean database. So again, capturing all procedures in this database. And you can see here, they have same thing, 115,000 patients in each group that they're able to match. This one was a little different because it also looked at primaries and revisions, and it showed the same thing, no association between the role of having an invasive dental procedure and developing a periprosthetic joint infection. So let's take a step back and just look at oral cavity, right? So we know the oral cavity is an indispensable part of the human microbiome, right? It's the top part of your gut, of your GI system. So there's over 6 billion bacteria that are living in your mouth and your GI system. And it's a commensal relationship. They all benefit from each other being there. But when you have poor oral hygiene is when you get this transformation from this shift from healthy oral flora to potentially pathologic. But interestingly enough, if you go back and look at the microbiology of infective endocarditis, which is really, again, what led to this charge, about 30 to 40% of cases were oral viridans, the group strep, right? So obviously there was some concern there. If you look at it from a total joint perspective, coag negative staph, staph aureus, gram negatives, our staph species actually account for less than 10% oral viridans, less than 3% of our microbiology. So a very different microbiology profile between infective endocarditis and periprosthetic joint infection. This is the interesting part, though. This is the crux of the whole thing here, which is bacteremia, right? That's the thing that we all worry about, going to the dentist, manipulating your gums and getting bacteremia. Well, this is studies that they've done where they've actually taken blood cultures for people doing routine activities every day, right? So assumed you all brushed your teeth this morning when you came in. If you flossed, right, you have a 20 to 68% chance that you were probably transiently bacteremic when you were doing that. Same thing with chewing food, chewing gum, using a water pick, right? So we're all getting transiently bacteremic all the time, right? So it's not just with invasive dental procedures. But of course, if your oral health changes to being poor, then your increased risk of becoming bacteremic goes up. You're at an increased risk of having bacteremia. And then the age-old question is, if you give somebody antibiotic prophylaxis, does it actually help at all? So this was an interesting study that they did where they took 221 patients and they gave them either amoxicillin, clindamycin, moxifloxacin an hour or two before they actually had their teeth extracted. And they took blood samples and blood cultures of them over that period of time, 30 seconds, 15 minutes, and 1 hour after extraction. And so the interesting thing is really antibiotic prophylaxis didn't even eliminate their bacteria in majority of cases, right? You can see compared to a control, right, high incidence of patients becoming bacteremia. Amoxicillin reduced it somewhat, but oftentimes not even by half. Clindamycin as an antibiotic, as most of you know, is pretty much totally useless, right? We shouldn't even be giving it at all. You can see it really didn't even reduce the incidence of bacteremia hardly at all. So even if you take the stance that antibiotic prophylaxis, we should be giving it, it's not working, even if you believe that there is that association that we talked about. So the challenges, of course, is what do we say as orthopedic surgeons, and I've been guilty of this, right? What's the harm? It's just a single dose of antibiotic, right? What's the big deal? You just need to be burned once by this. Almost every time I give a grand round, someone in the room stands up and say, I had a patient one time that went to the dentist and came back in with their knee, blown up the next day. And then the other thing that most commonly, right, of course, in the US is I'm not getting sued if a patient gets a periprosthetic joint infection from having dental work, right? So we should talk a little bit about each of these. So what's the harm, right? Anaphylaxis, right? It's a big deal. The problem is we as orthopedic surgeons don't necessarily always see this. GI distress, C. diff, and antibiotic resistance, right? These are all real problems. And C. diff colitis is, as I've looked into this, it's a big problem, and it's a growing incidence as we continue to give more and more patients antibiotics, right? So risk factors, IV or oral antibiotics, recent hospitalizations, age greater than 65, that's pretty much all of our total joint replacement patients, right? 13 deaths per million patients with a single dose of clindamycin, And the interesting thing is it doesn't necessarily happen right away. Oftentimes they can develop C. diff colitis 3 months out from even just taking that single dose. So much likely we're certainly not going to tie it back to that. And then this is purely just anecdotal, and I've looked this up. I'm not an attorney. I could not find a single case of a lawsuit against a dentist or an orthopedic surgeon for not prescribing antibiotics. I did come across one case of a lawsuit against a dentist for prescribing antibiotics and the patient got C. diff colitis, right? Again, that's purely just anecdotal. And then the other challenging issue that we have is new antibiotic development, right? It's virtually non-existent. Can anybody name to me like 3 or 4 new antibiotics that have come on the market in the past 4 or 5 years? It's really hard to do, right? It's really hard because pharmaceutical companies are not focusing their attention on this. In their mind, it's relatively small compared to some of the other problems that are out there. And if you look at this antibiotic pipeline, 10 to 15 years and $1.3 billion to develop a new antibiotic. So oftentimes it falls into what they call this valley of death. And the fact of the matter is most big pharma companies are not putting their attention in developing new and novel antibiotics, right? This is where all the attention is going because this is where the money is, right? Ozempic, these GLP-1 agonists are poised to be the most prescribed medication in like the history of medicine. I mean, it's really, really unbelievable. And I don't think we should minimize our role in antimicrobial resistance. It's real. It is going to ultimately potentially surpass cancer in lethality over the next 20 or 30 years if we continue on this same trajectory. And we're seeing it here. This is a study that we published looking at our periprosthetic joint infections and the microbiology and the incidence of resistant bacteria are actually going up in our periprosthetic joint infections. And so the question is this a problem that we are creating? And then the other thing that I'll say is that we're outliers, right? And it's probably time for us to evolve. These are all developed countries that do not and never have recommended antibiotic prophylaxis for joint replacement, right? And but we still continue to do it. And so we remain outliers in this world. And when I, talk to colleagues from around the world, they think we're crazy for doing this. They think we're just absolutely crazy. They don't understand it. And then what about other, procedures, urologic procedures, GI procedures, things like that? We get patients that call in all the time. I'm having a colonoscopy next week. Do I need to take antibiotics? Well, the GI guidelines are actually even more stricter than any other guidelines that's out there about not recommending antibiotic prophylaxis for patients having manipulation of their GI tract. And this is what they say. It's remarkable that most endoscopic procedures are less risky than brushing your teeth. Although one would think that manipulating the GI tract, particularly the colon, would lead to a great deal of bacteremia. However, published studies have not demonstrated an increased risk of bacteremia in patients from endoscopic procedures of the colon or other endoscopic procedures. Although some physicians want to err on the side of caution and prescribe antibiotics to prevent a possible infection, there's a risk-benefit ratio to giving antibiotics, as antibiotics have adverse reactions, all the things that we talked about, right? That's a great summary slide, really, for all of these things that we're talking about. And even the cardiologists have evolved over time with this, right? 1955, antibiotic prophylaxis for every single patient. Now what they're saying in their most recent guideline is infective endocarditis much more likely to result from a frequent exposure to random bacteremias. Prophylaxis may prevent an exceedingly small number of cases. The risk of antibiotic-associated adverse events exceeds the benefit of giving antibiotics, and maintenance of optimal oral health is really the key. So for surgeons, this has always been a high-value, low-risk proposition. Patients are often stuck in the middle, and in the absence of evidence, we have always practiced defensive medicine, right? It's just the easiest thing to do. What do we do, or what did we decide to do here as a group? And again, this is about starting that conversation. So for my entire practice here for 18 years, we gave it to everybody for their entire life, right? And so we started having this conversation. It's hard to get everybody to agree on the exact same protocol. So we said we prefer patients to wait 3 months before having dental work after total joint replacement. Makes sense, not a lot of data behind it. Antibiotics for 1 year after their joint replacement. Doesn't make a lot of sense, but okay, that's kind of what we agreed upon. And then antibiotic prophylaxis for high-risk patients, immunocompromised patients, prior PJI, Immunocompromised is kind of where do you draw the line, right? Who's immunocompromised, who's not immunocompromised. But as I said in the beginning, we started the conversation and we made a change. We're now no longer giving this to everybody for the rest of their life. We've shrunk it down to, I think, which are reasonable recommendations. And hopefully that'll make a difference. And as this continues to evolve, and the Academy has already started to develop their next set of guidelines, hopefully taking some of this newer literature into consideration. So most recent data suggests no association and no protective benefit of a patient receiving antibiotic prophylaxis. There's no question there's increased risk of antimicrobial resistance and adverse reaction. And I think in the presence of evidence, we should practice evidence-based medicine. So I'll go ahead and stop there. I can entertain any questions on this subject, and I think we'll have time to ramble through the next one.
Oh, great. I definitely want to hear your second talk, so we'll try and keep things short. Just one quick question I had. Any evidence in the megaprostheses world? So
yeah,
most of our patients are, even though you think that they get chemotherapy, they're not chronically immunocompromised. So a kid with osteosarcoma gets their joint and they're going to have that megaprosthesis their whole life.
So I think this gets back to that, individual kind of patient decision factors, risk benefit ratio, right? If like oftentimes you hear the ID person say, if that patient gets an infection, right, they might be losing their leg. There's no studies that looked at it in the mega prosthetic world. That one study from Core looked at revisions, but they didn't parse it out by how big the construct was. I still think in those cases, right, risk benefit ratio in that situation, if they're immunocompromised or on chemo and they get an infection, you can make that argument that that's okay to do that. But I think for these routine primary total joint replacements, it doesn't make a lot of sense. Okay. All right. So I'm going to roll into this next one, and I will tell you that this is a very disjointed talk. So the reason is kind of the way that I tend to do this is, I'll hear something, I'll read a book, I'll listen to a mentor, I'll go to a talk, I'll jot down some notes, and I'll go home and I'll make a slide about it, right? And then I just kind of cobble this all together. So it's in no order. This is for as much for myself and lifelong learning as it is, but it's a talk I give to the fellows at the end of the year. It's a talk that I'll occasionally give at some other courses about just kind of lessons that I've learned, mistakes that I've made, kind of going through this process of learning. If it can benefit you all from learning from this, then hopefully it's worth it. But we talk a lot about this issue of work-life balance. I don't know if that's really the right word that we should be using. Perhaps it's a misnomer. I know a lot of people that do it well. I know a lot of people that certainly do it way better than I do, but I don't know if there's a perfect way to do it simply because of the practice of medicine, right? It's your life's work. And when what you do is your life's work, it makes it hard to parse out that difference. But no question that burnout is real, right? None of us are immune to it. We all face it. And it's a matter of how you can best figure out how to deal with it in your own individual lives. And you probably learn a lot from each other on this topic, but it's real. And it continues to be a challenge, probably more so now than what it ever has been in the past. I love the quote that medicine is like a jealous mistress, she'll settle for no less. I oftentimes, and you guys probably do this as well, when you're driving home at night, wish you could just turn it off, right? Like that you worked at a bank or you did something else. And when you leave at 5 o'clock, you can turn it off at 5 o'clock and turn it back on again at 8 o'clock, the next morning, but you can't, right? You chose a profession where you are always on, right? You always are on and you always have to be on in some sense. And so that requires a lot of personal sacrifice, right? That's just the decision that we made when we decided to go into medicine. And there's ways that you can all learn to balance that, and you all do a very good job of doing that. But this is no question, is a personal sacrifice profession. I'll tie a lot of what I've learned over time from books, and I'll kind of give you my philosophy about reading books, because I probably went for like 48 years of my life never reading a book. And now I'm reading books, all the time whenever I can. And I'll talk a little bit about that, and I'll kind of pull out, what I think some of the important factors are. But if you look at kind of tools for success, and this is true for any any qualities that you have, any leadership qualities you have across any companies, regardless of medicine, they always say you need to have the 3 Qs, right? You have to have some intelligence. You have to have some financial intelligence, what they call an FQ. But if you look across most successful companies and most leaders, the biggest Q that they have is an EQ. It's an emotional intelligence, right? And the good news is that can be learned. You don't have to be born with it. It can be learned. It can be taught. You can learn from many of your mentors in this world that really have high IQ levels. And I like to tie everything kind of to orthopedics with bones, right? So you need a backbone, a wishbone, and a funny bone, right? Those are the 3 most important bones I think that you can have in orthopedics. I personally think that the word leadership should never be said without using the word servant leadership, right? And I think we've gotten away from this in this kind of world where everything's about yourself and everything's about an individual. These are my 2 favorite books on leadership. Nelson Mandela's Long Walk to Freedom, which is his biography that he wrote while he was in prison on a little piece of paper that he would send out, sneak out of prison, and then be able to cobble it together. And then Abraham Lincoln's book on Team of Rivals. 2 incredible leaders from our past that we can all learn a lot from that were exceedingly high on the IQ scale. And Nelson Mandela's quote on leadership is one of my favorite. A leader is like a shepherd. He stays behind the flock, letting the most nimble go on ahead, whereupon the others will follow, not realizing all along that they're being led from behind, right? That to me is kind of the ultimate definition of servant leadership. So if you have an opportunity, pick up those 2 books. They're both really long. The Lincoln one took me about a year to read because it's about 1,200 pages, but nonetheless worth a read. This kind of philosophy of connecting the dots is kind of one of the coolest things that's I think has kind of happened to me as I've gone along my career, being able to take people and connect them together, you know, whether it's in a department, whether it's in a hospital system, whether it's around the country or around the world. And I think the most important thing that you can do as you all go out into practice and you think about investing is invest in people, right? And surround yourself with really smart people, right? Warren Buffett said, if you're the smartest person in the room, then you're in the wrong room, right? And I think that's really important to think about. As a good leader, surround yourself with people that are better than you, that are smarter than you, that can help you learn and grow. And this is kind of tying this together with this kind of connecting the dots thing. Does anybody know who Peter Lockhart is? Okay, a couple of you do. So Peter Lockhart was the chair of the Department of Dentistry at Atrium for a long time, right? Most of you have never heard of him. He's probably one of the most published and prolific researchers on dental work, probably in the world, right? I mean, Rachel, am I right? I mean, he's retired now. He's phenomenal. He's the one that reached out to me about this study, probably connected through somebody else. As I said, right, I was dumb enough to say yes, that I would want to do it. And he and I have kind of formed this bond. He's retired now, but when he comes to visit, we get together and we talk about this. And he's connected me with Martin Thornhill, who's a PhD researcher who's in England, who helped develop this kind of case crossover methodology. It's led to 4 other publications. I've been fortunate enough on this topic to give grand rounds at SIU, Vermont, Georgetown, Yale, and now here, and have connected with other authors on this paper that have now led to other studies. We're doing one now on GLP-1 agonists and total joint replacement, right? So it's all about connecting the dots and connecting people together and how much that can, and not just in medicine, but just in life in general, right? One of the things that ties your happiness in life together is your connections with other people. And so just think about that as you go through your career. Don't necessarily push off the person that's in another subspecialty or may not have the same interest as you, because you'd be surprised how that connecting dots can make a big difference. If there's one book I think, and I give this book to our fellows every year they graduate, it's called Essentialism. It's about control and time. The one thing I'll say when you all finish residency that you get back that you've never had before in your life is control over your own time, right? And what you decide to do with that is exceedingly important, especially in the first 5 years of your life. If you don't prioritize things in your life, other people are happy to do it for you, right? And you have to really take control of it. As I always say, it's easy to say no to the things that you don't want to do. It's hard to say no to the things that you do want to do, right? But keep in mind, and this is true for work, this is true for family, this is true for everything in life. When you say yes to something, you're saying no to something else, right? So if you're saying yes to going to that meeting at 6 o'clock, you might be saying no to missing your son's baseball game, right? So think about that. That's important, and read that book. I'm a list person, right? So I always try and prioritize things. I keep lists everywhere. I have these on my desk, and I write a list of everything that I'm currently doing, right? And then I go through it every once in a while, and I just cross things off, right? As I prioritize things, this is no longer important to me. This is no longer important to me. You know, I can have someone else do this. So it helps me to kind of prioritize things that are important in my life. We tie so much nowadays in our lives, and especially in our practices, to how busy you are, right? How busy you are somehow seems to be tied to success. Oh, he's a great surgeon. He does 1,000 joints a year. I've seen people do 1,000 joints a year that are pretty bad, right? So be careful about tying success purely to volume. Don't let medicine become a business. You all have a gift when you leave here that very few people in this world have, which is the ability to make people better and have a lasting impact on your lives, right? Don't treat them like a commodity. It's not just another hip. It's not just another knee, right? It's a patient on the other end of that. So volume should not be your only measure of success. You can create practices that are so busy that you actually keep the people that need to see you the most out of that practice. And just, be careful about doing that. Always leave room for patients that need you, whether that's a phone call, returning a message, or getting them into the office to see them. Because remember, patients are really entrusting their lives with you. And sometimes it's hard to gather that when you're doing a 15-minute, new patient consult. The least you can do is take time to listen to them and do your best in surgery for them every single time that you walk into the room. Don't confuse speed with quality, right? Speed does not equal efficiency. They're separate. Speed is this is actually one of my chief residents when I was a resident in Mayo. He said, speed is the result of good surgery. It does not result in good surgery, right? So just going fast does not make you a good surgeon. As you get better and more efficient, then the time aspects will come with that as well. This is the old slow is smooth, smooth is fast, right? You all operate with incredible surgeons here, and things seem like they're going slow and smooth, but in actuality, it actually has gone relatively quickly, but you haven't really noticed that because things go so smooth, how things tend to flow. Bill Harris, who's a legend in hip and knee replacement, talked about what do you do in the OR when you have a complication? What are you going to do when you don't know what to do? What are you going to do when you don't know what to do? And the answer is, don't just do something, stand there. So it's not don't just stand there, do something. It's don't just do something, stand there. And this, Bo Mason taught me about this, and he's really good at this. When he has a complication or an issue, he stops, he walks to the back of the room to the table, he picks up a pen, he writes down what all of his options are, sometimes scrub out for a few minutes, gather and collect yourself, and then come back in and figure out what you're going to do, make that decision. But don't make a rash or a rush judgment, because things just tend to compound themselves and they get bigger and bigger. Never walk out of the OR and say, I wish I had done that. Do it. The worst thing you can say in the OR is, I'm sure it'll be fine, right? Because almost never is it actually fine. Tom Faring, one of my greatest mentors, taught me this when I was young, and he tells all of our partners this, and this is so exceedingly important. Run towards your complications, not away from them, right? They don't go away if you run away from them. Run towards them. If you have a patient that has a complication, those should be the ones that you're calling. Those should be the ones that you're seeing frequently, right? We all know patients generally don't tend to sue because of a complication. They generally tend to sue because they feel abandoned, because they feel lost, because they can't get answers, right? So keep those patients always on my little index cards that I carry on the backside. Keep a list of all my patients that have had complications. Sometimes it can get pretty long, and what I'll occasionally do is just call them randomly on the way home on a Thursday, on a Saturday morning. Hey, how you doing? How you feeling? Everything okay? And you'd be amazed how those become some of your most special patients in your career. Be good to your staff. This is critical. The worst thing you can do when you go in to start a practice is go in with guns blazing, pretending like you know anything, right? Some people cause happiness wherever they go, others whenever they go, right? So you're right, when at the end of the year, if the staff is really going to miss you, right, then you know that you've done the right thing. If they're anxious for you to go, then maybe you should think about it again. For me, this is kind of one of the biggest things, and these are lessons that I've learned the hard way over time, which is communication. So I have this thing called the 24-hour rule. I don't think I made it up myself. Someone probably shared it with me, which is if I get an email or a text message or anything that makes the hair on the back of my neck stand up, don't answer it. Either just delete it and let someone else do it for you, because invariably there's someone that'll respond to that right away and make themselves look stupid. Or write the draft of the email and save it in your draft box, and come back 24 hours later and read it again. And you'd be amazed how oftentimes you'll say, boy, am I glad I didn't send that email. And it has cost me a lot over time, and it's saved me a lot over time by being able to do that. Be careful with text messages, because you can't always necessarily convey context. And I always say, just pick up the phone and call someone. Walk down the hallway and have a conversation with them in person. Conversations that you have with people in person are very different than when you're just reading words on the screen, right? Communication. Be a good listener, right? The key to a negotiation is understanding the other person's argument better than they understand it themselves, right? That's really the key to negotiation. You're the only person that sees the world through your eyes. I think that's really important we get away from that. You're the only person that sees the world through your eyes. Nobody else does. And if you go into a conversation or a discussion with people thinking that they only see things the way you do, then you're not going to come away with very much. The book by Chris Voss, Never Split the Difference, where he talks about tactical empathy, is a great book to read. We all make enough money. We all make enough money. For you all, when you're leaving and going out into your fellowships and your residency, my advice is generally live like a resident for the first 5 years, right? The last thing you want to do is become house poor and car poor and have all those financial struggles. I have a bigger talk on not doing anything with industry for 5 years, so I won't necessarily belabor that. But I love this, that no one is impressed with your possessions more than you are, right? No one is impressed with your possessions more than you are. For patients, don't ever let money drive your decision-making when it comes to the care of patients. For children, give your children enough so that they can do something, but not so much that they do nothing, right? And that's the balancing act in the world we live in, where we're all, making money, and we have kids and we want them to be better off, than we were. This is important, especially as you get older in your career. This is really important. Be addicted to something, preferably not drugs or alcohol or something like that, but find something else outside of medicine that is your addiction, right? That is not medicine, that's outside of medicine, that you have something to turn to, so that when you get older, you have balance, and when you get ready to retire, you can walk away and have something else to turn to. This is huge for me. I read this book, Stolen Focus, about 2 years ago, and it honestly kind of changed my life with like social media and everything like that. Your attention span has been stolen from you intentionally with social media and our phones and distractions. And so it was actually 2 years ago in January, I did this thing called a social media cleanse. You should all try and do it. I actually did it and never went back. I just got rid of everything that was social media off my phone and just got rid of it. And I said, I'm no longer going to sit in my bed at night and look at Instagram for 15 minutes. I'm going to pick up a book and read a book for 15 minutes. And honestly, from my personal perspective, it's kind of changed my life. This addiction to distraction is real, right? How many people can sit down and read a journal article and not look at their phone while they're reading the whole journal article? It's impossible. Try and do it. It's really hard to do. And that's because our brains have been rewired for these little snippets, these little, infinite scrollings. It's really amazing to read kind of the science behind that. But if you get a chance, read the book or listen to the book, Stolen Focus. And as I said, it's kind of changed my life, because when you listen to a podcast, an author preps that for an hour. If you read an article, an author spends maybe a couple of weeks on doing that. If you read a book, an author has spent 5, 7, 10 years of their life writing that book, and you're able to get all of that information down into, a several-hour read or a listen or something like that. And, so this is what my bookshelf looks like now that sits next to my bed. It used to be completely empty. I said for 48 years of my life, I never read a book. And now I'm reading, every night before I go to bed. Your life outside of medicine, as I say, try and compartmentalize your life. It's really hard to do that. When you're home, be with your family. When you're at work, be at work. For those of you kind of in the younger age, if you want to read, one of the best time management books is 4,000 Weeks. Anyone know what 4,000 weeks is? That's our average lifespan. 4,000 weeks is the average time that a human lives. Pretty scary to think about that, right? For those that are in mid-career, older career, read From Strength to Strength. It's an incredible book. I felt like it was directed at me, but it talks about how your intelligence changes over time in your career and how you can best share that with others. You all know that I'm big on this. You all more than any program that I've ever been a part of do this better than any other place that I've ever been to, which is you give back, right? Joseph's in Tanzania right now. Some of you have been on op walk, trips with us. It's the most fulfilling thing that you will do in your life, is taking your time and your talent that has no reimbursement and giving it back to someone else. And then lastly, I'll kind of leave with this. This is kind of applicable because 18 years ago when I started, I'll never forget this with our old CEO, Pete Templeton. I was sitting up in my office when we were over at Randolph Road, and it was about 8:30, 9 o'clock at night. And I was sitting in my office working on a paper, and he kicked open the door and he said, "What are you doing here?" I said, "Well, I'm finishing a paper. I got this paper deadline I want to finish." He said, "Okay." But he said, in 30 years when you retire, that paper's not going to be your legacy, right? He's like, your family's going to be your legacy. So think about that. Thanks to all of you guys, mentors, teachers, colleagues, residents, fellows, staff. I kind of had to put this together last minute, so I didn't get a chance to do as much reflection as I wanted to. But when I was cleaning out my office a couple weeks ago, I was sorry. I was putting away all my plaques and everything, and I only kept one of them out. And it was this one. So sorry, didn't think I'd get emotional, but thanks very much, and look forward with being able to continue to connect the dots with you all. Thank you.
Meant and done for us.
Thank you. Happy to answer any questions.
Dr. Springer,